Hello everyone, this is Dr. Fox, and let's talk about cardiac conduction and control. In this video, we'll discuss the cardiac cycle, specifically systole versus diastole, and what's happening with the chambers, valves, and blood flow. We'll discuss the cardiac conduction system, mapping out the nodes, fibers, rates at nodes, influences, and contractions. We'll also discuss extrinsic or autonomic control of the heart and how it's organized into cardiac plexuses. Finally, we'll discuss normal sinus rhythm versus arrhythmias. So let's begin with the cardiac cycle. First, we must acknowledge that the movement of blood is entirely pressure driven. So blood is going to move from areas of higher pressure to areas of lower pressure. And when we discuss pressure, it's also important that we discuss its relationship to volume. That is, volume is inversely proportional to pressure. So whenever volume increases, pressure will decrease. Whenever volume decreases, pressure increases. So let's look at this in the context of the cardiac cycle. Let's start with diastole. Whenever I think of diastole, I think of dilation. So the chambers of the heart are dilating, they're relaxing, they're getting larger. As such, their volume is increasing and pressure is decreasing. Because pressure is decreasing, blood is flowing into the heart. In fact, nearly 3/4 of the blood that's going to get pumped out during ventricular systole is going to flow through during diastole. Following diastole, what happens is the atria contract. So we go through a period of atrial systole. So blood is still moving through the open atrioventricular valves. The semilunar valves are closed, and the ventricles are becoming maximally filled. This is a time known as atrial kick because you get that extra quarter of blood flow in there. Following atrial systole, we have ventricular systole. And there are two parts to this, but what happens is basically the ventricles, which are maximally full of blood, contract and eject that blood out into the ascending aorta and pulmonary trunks. We follow this up with diastole, rinse and repeat. So we're in this constant cycle of diastole and systole. So we could break ventricular systole, or just what people refer to as systole, like when you take systolic blood pressure, you're measuring their blood pressure during ventricular systole, into two parts. The first part is something known as isovolumetric ventricular contraction. And what's happening here is that the ventricles are just beginning to contract, and all the valves, both atrioventricular and semilunar valves, are closed. Following isovolumetric ventricular contraction, we have the completion of ventricular systole, where the semilunar valves open up. The atrioventricular valves are still closed because they are driven closed by the increase of ventricular pressure, and blood is ejected forward into the ascending aorta and pulmonary trunks. Now let's talk about what drives all of this, and that is cardiac conduction. Whenever someone looks at an illustration of cardiac conduction, they think that there must be nerves or nerve fibers within the heart that are conducting all of these things. But in fact, everything that's illustrated here as part of that conduction system is just a specialized cardiomyocyte. Recall that cardiac muscle tissue is capable of autorhythmic depolarization, but there are certain clusters of cardiomyocytes that can set the tempo or the tone for depolarization. One of the more important regions is that of the sinoatrial node. Some people call this the sinoatrial node, or just the SA node for short. This is what we refer to as the heart's pacemaking region. It's found at the superior aspect of the crista terminalis, just subepicardially, and its intrinsic rate is 100 beats per minute. Now, most people don't typically have a resting heart rate of 100 beats per minute. That's pretty high. And so we'll know off the bat that the SA node can be influenced extrinsically, specifically by the autonomic nervous system, organized into two parts that collectively we would refer to as the cardiac plexus. We understand that the autonomic nervous system has two divisions: the sympathetic division, which, among other things, increases heart rate, and the parasympathetic division, which, among other things, decreases heart rate. So we know that at rest, the parasympathetic stimulation is what dominates from the cardiac plexus and reduces that intrinsic rate of 100 beats per minute down to, I don't know, maybe 60 or 70 beats per minute. From the SA node, depolarization is going to spread throughout the atria, and it will come to a specialized node that rests within the atrioventricular septum. That's the septum between the right atrium and the left ventricle, called the atrioventricular node. So it is appropriately named. The AV node's intrinsic rate is between 40 to 60 beats per minute. So it is lower than that of the SA node. When this depolarizes, that is going distally towards the atrioventricular bundle, also known as the bundle of His. The AV bundle has an intrinsic rate of 20 to 35 beats per minute, and it is nestled within the interventricular septum. Also coming down from the interventricular septum are the bundle branches. We can see that ascend or descending on either side. There are right and left bundle branches, and the right bundle branch will take a shortcut through the septomarginal trabecula, or the moderator band. These bundle branches will terminate into Purkinje fibers throughout the ventricles. And when well coordinated, we have a series of diastolic events followed by atrial systole, followed by ventricular systole. So it's well coordinated, well timed output. Any sort of interruption or disruption to this conductive pathway is something known as cardiac arrest. Oftentimes, people will conflate cardiac arrests with heart attacks. Heart attacks are events which are modulated by interruptions of the vascular system. So if there is some sort of atherosclerosis or a clot that interrupts the coronary arteries or a branch, that would be a heart attack. If there is, something which interrupts the conductive pathways, that's referred to as cardiac arrest. So let's talk about that extrinsic control of heart rate. So the autonomic nervous system is organized into cardiac plexuses in the vicinity of the heart from fibers of the vagus nerve and the sympathetic trunks. So the autonomic nervous system has both a sympathetic and a parasympathetic side to it. The sympathetic is the fight or flight. The parasympathetic is the rest and digest. And so the vagus nerve, or cranial nerve 10, is one of 4 parasympathetic outflows from the brain. And it has a lot to do with autonomics, specifically parasympathetics of the neck, the thorax, and the abdomen. Specifically for the heart, with vagal stimulation, that slows rate and dilates coronary arteries. The sympathetic contribution to the cardiac plexus comes from preganglionic fibers from T1 through T4 or 5. So that's what goes out to the sympathetic trunks. And then from the trunks, we have cardiac accelerator nerves. These cardiac accelerator nerves then participate in the cardiac plexuses. And with sympathetic stimulation, we have an increase of rate. And while we have some constriction of the cardiac vessels, there is some beta 2 dilation with it. And with the increase of blood flow through an increased rate, we have increased perfusion of the heart. So that's just a minor effect of constriction on those coronary arteries. So cardiac plexuses are what work upon the SA node. Now let's discuss the cardiac plexuses. So all of those fibers are organized about, the regions of the heart. There are two of these. There's a superficial cardiac plexus, which nestles in the concavity of the arch of the aorta. And there is a deep cardiac plexus that is found just superficial to the tracheal bifurcation into the primary bronchi. This one is contiguous with the pulmonary plexuses, which are lateral to that on either side of the primary bronchi. So these together form the cardiac plexus that is then going to affect the rate of the SA node. Now, heart rate is one of the things that we can measure, and we can keep track of the electrical stimuli or the electrical signals from the heart with something called an electrocardiogram or an EKG. Heart rate is going to correspond to pulse rate, and normal sinus rhythm is a normal or a typical EKG with a heart rate between 60 to 100 beats per minute. Anything slower than 60 beats per minute is something known as bradycardia, brady meaning slower. Anything higher than 100 beats per minute is something known as tachycardia. Tachy meaning faster. And so here we can see examples of bradycardia and tachycardia. There are also arrhythmias. Arrhythmia means an abnormal rhythm, but technically this means without rhythm. We refer to these as dysrhythmias, and there are two general categories. There's that of bradyarrhythmias, those which are slower, and tachyarrhythmias, those which are faster. So of the bradyarrhythmias, so sinus node dysfunction, anything where the SA node is running slower than typical. There are also various degrees of atrioventricular blocks whereby the signal either is being slowed or even stopped through the AV node and bundle branches. With tachyarrhythmia, the two most common are atrial fibrillation or ventricular fibrillation, so that's AFib or VFib respectively. AFib is generally a chronic condition, but it can be problematic from the perspective of throwing a blood clot. It's very manageable with medications. Ventricular fibrillation may be absolutely deadly, and it's considered an emergent event because when the ventricles go through this process of fibrillation, it's uncoordinated contraction. And so they're not pumping the blood out to the lungs and to the systemic loop. And that is something that needs to be corrected either with medication and a shock through defibrillation such that we can get back to a normal sinus rhythm. So let's assess the knowledge. Fibers that cause a depression of heart rate are conducted by which nervous structures? Cardiac nerves, if they are cardiac decelerator nerves, branches of the vagus nerve, yes. Postganglionic sympathetic fibers, no. Preganglionic sympathetic fibers, no. Both of these increase heart rate. Vagus nerves, yes. So cardiac decelerator nerves that are branches of the vagus nerve would be the best answer here. Thank you so much for your time, and I look forward to talking to you in the next video. Take care.